swallowing dysfunction and aspiration, how to support those meal times practically, and some other factors to consider, and obviously when to contact us. Next slide, please, Kerry. So, what is dysphagia? Dysphagia is the medical term for swallowing difficulties. So some people with dysphagia have problems swallowing certain consistencies of food or liquid, or both, and others can't swallow at all. The main indicator of this is that food entering the windpipe, so that going down the wrong way feeling that we all have occasionally, I'm sure, and that coughing and choking that you notice during or just after a swallow. Other indicators of dysphagia that quite often prompt a referral to us are loss of weight, which quite often comes from a loss of appetite, and persistent refusal. That persistent refusal is quite often a communication that something might not be going quite right. Obviously, chest infections we always ask about, signs of pain or discomfort during meal times, that flushing or pale skin that you might get, watering eyes. Sometimes we have those autonomic responses, so sneezing or burping quite regularly during a meal time can be an indicator of something not going quite right, and then that gurgly kind of wet sounding voice that we listen out for, or breathlessness, of course, during meal times. So the risks, obviously, dysphagia and problems with eating and drinking can be life-threatening. So if it's not managed safely, the swallowing difficulties can lead to respiratory tract infections, and getting those repeatedly, and those chest infections repeatedly, means recovery becomes increasingly lengthy, and can lead to things like scar tissue on the lungs. Dysphagia occurs in between 31 to 99% of children with cerebral palsy, which seems like a massive scope to me, but that's quite often due to its nature, which I'll go on to in just a second. Around 44% of children with neurodevelopmental disabilities, and is a complication in up to 93% of patients admitted to brain injury rehab. It's also present in up to 40% of infants born prematurely, and around 68% of children with acquired conditions in the acute phase of care. That's dysphagia, those types of dysphagia that I was talking about, can be an intermittent dysphagia, a kind of transient dysphagia, a steady or kind of stunted decline, or a static dysphagia. And obviously in the acute phase of care, you quite often get some improvement there too. So the other risks that we know about are pneumonia, so there's recurrent chest infections, and the respiratory tract infections can lead to a pneumonia. Poor hydration and nutrition, which can lead to significant weight loss, malnutrition, and dehydration. And those really scary, turning blue in the face, obstructive choking episodes that require that physical intervention. Thanks, Kerry. So before looking at dysphagia a little bit more in depth, it's really important to understand what the normal swallow looks like a little bit more. So obviously it's a really complex mechanism. There's the 4 stages, so oral, preparatory, oral, pharyngeal, and esophageal. So the whole process involves around 26 muscles, and 7 of our 12 cranial nerves have some involvement in the process from start to finish. We have to be able to coordinate all of this super quickly, and without even thinking about it. A couple of the stages are involuntary, so it just happens without us having to think. And if we don't do this properly or in the right order, then that food or drink will go down the wrong way, which is when the problems occur. Thanks, Kerry. So these 4 stages, where the red dot is, you've got the oral prep stage. So this stage happens before the individual even opens their mouth, and is dependent on the consistency of the bolus and saliva management. So fluid management includes saliva management. Level of thirst and hunger, visual and olfactory information, the emotional state of somebody, the texture of the food being presented to them, their motor skills, coordination, etc. all of that has a massive influence on the oral prep stage. So when a speech therapist would be coming to assess, they would be looking at all of that before you even start the feeding element of the assessment. Saliva is obviously essential. And that production of saliva comes from being able to see, smell, taste all of that food. And it's essential here for dental and mucosal protection. The oral pH, so the balance in your mouth, antimicrobial action, and most importantly, obviously, lubricating the mouth so that bolus is formed really, really nicely for a nice safe swallow. This is obviously a voluntary stage, so the individual will see what they're being offered to eat or drink, be told what it is, and coordinate the muscles and limbs to steady themselves, to give that appropriate proprioception, lift the cutlery, eat appropriately and bring it to their mouth, cut appropriately and bring it to their mouth. Where that yellow dot is, so that's your oral stage. Again, it's a voluntary stage. The individual opens their mouth ready to receive the food. The food is then placed in the mouth. It mixes with the saliva and is chewed and manipulated. It's prepared into a bolus, so kind of a single formation for swallowing, using the tongue, teeth and movement of the jaw along with the hard palate. So that bit that you can see at the top there. The bolus is propelled to the back of the mouth using a ripple effect of the tongue movement. And this triggers the beginning of the automatic swallowing reflex. So where the green dot is, that's where your pharyngeal stage happens. So this is the start of an involuntary stage and is a rapid sequence of overlapping events that last a single second. So this is quite often where things go wrong. The soft palate rises, the whole larynx, so this bit down here, rises upward and slightly forward. Both sets of your vocal cords close to protect the airway. The epiglottis, so the flat bit that you can see just where the green dot is, that's pulled down over the trachea, so your windpipe, to protect it. And the back of the tongue, all the way down the back there, pushes the bolus down. The walls of the back of the throat expand and the esophagus relaxes, ready to accept that food. And then your last stage, your esophageal stage, is also involuntary. So the muscles down where the blue dot is contract in a kind of movement like this, which is called peristalsis. And this moves the bolus down from the esophagus into the stomach and can take between 2 and 20 seconds. It can be virtually impossible to swallow if the esophagus is full or emptying slowly. So yeah, those are your 4 stages. Next slide, please, Kerry. So when we think about the abnormal swallow, or think about why we might be called or contacted in the first place. So the dysphagia is diagnosed if a problem exists at any of those stages for us. So you might have an inability to form that bolus, or only a partial formation, or difficulty manipulating specific consistencies of food. And that can be due to a coordination or a weakness difficulty in your mouth, tongue, jaw, etc. At the pharyngeal stage, you might have a delayed trigger or an uncoordinated series of those events that I've just been speaking about, allowing food or fluids to enter the airway. And then the esophageal phase, you quite often will see food being brought back up, or a slow or uncoordinated esophageal motility. So now the fun bit, considerations at mealtimes. So obviously it's really, really important to us that nutrition and hydration is offered at the correct consistency. So when you see a speech and language therapist for a dysphagia assessment, you will be given some IDSI guidelines, which are multinational guidelines that everyone follows and kind of standardizes their assessment by. So along with the stage that you were given, you will also be given guidelines along with that. So the sorts of foods that fit into that stage, how they should be prepared and what they should look like. It's really important to ensure that those meals are really well balanced, as well as being safe, which is quite often why our dietitians get involved and things like that. And then Adequate hydration is obviously vital, and inadequate fluid can lead to that infection and difficulty maintaining focus and attention. So that's always something that we'll speak about at dysphagia assessments, making sure that they've got that adequate hydration and there's no sign of water infections or anything like that. So staffing is a really, really important one, especially in schools and day centres. It's often really either very tricky to get regular staff, or the opposite occurs and there is only one member of staff that feeds the individual, supports that individual during a mealtime. The difficulty with either one of those is trust and confidence. So if there's only one member of staff that's feeding that child or young adult or supporting them, you then end up with a reliance and a dependence on that person. And then if they are unwell, then the other members of staff don't have that confidence to hop in. Equally, if you've got a different member of staff every single day, that child or young adult doesn't get that opportunity to build that trust and that confidence in the person supporting them. So obviously we promote training. So training increases that confidence. Mealtime and catering staff, really, really important to get them involved as well. Need to understand how to present the food in appropriate consistency, as I was talking about just before, for each child, and how best to support them, including the risks of an unsafe mealtime. So all of this staffing and this trust and confidence leads to a child or young person's independence skills. Obviously, part of the assessment is looking at their independence and the active role that they can take in assisting or self-feeding, even if it's just for part of the meal, and whether there's any equipment that might be able to support them with that. Without that independence and that level of independence, you get a change in attitude to meal times, potentially reduced fluid intake. So there are lots of risks to ignoring the child or young person's voice and their opinion on what they might want. Thanks, Kerry. Positioning is obviously a really, really important one. That good positioning is fundamental to the development of safe and enjoyable meal times. Function depends on posture, which is that active and dynamic movement, and positioning, which is static and inactive in the way that you are seated. And that's all assessed by physio and occupational therapy to determine the right equipment. Perfect posture involves symmetry, an extended or upright trunk wherever possible, supported limbs, which is why we always look at things like with their feet and really nicely planted on feet on the floor, promotes natural kind of safety, and flexion in the hips and the knees. Mealtime care plans should always make reference to specific seating that is deemed safest and most suitable for an individual when eating or drinking, and will always include a specific position that they should be in. But this also refers to the positioning of the supporting adult. So in terms of comfort and effect for the child or the adult, making sure that you're not going to end up with a bad back. What you're after is seated, preferably in front of them, so you can have that communication with the child or young person, but you can also have that observation of when those real subtleties might be going wrong, like that eye watering, like that flushing, the things that you might not notice if you are feeding somebody, or feeding somebody kind of next to them but talking to somebody else and that kind of thing. It's really, really important that the positioning of the person feeding is also noted in the mealtime care plan. Thanks, Kerry. Communication. I could talk about communication all day, every day, obviously, as is my job. Mealtimes have a really, really important role in enhancing the development of communication skills. So that social communication with their peers, that choice making and that allowing their voice to be heard about preferences, and also commenting on whether they don't or do like something. It's really, really vital that anyone supporting the child or young adult knows them, which is what I said about staffing, to be able to identify that nonverbal communication and not just listening to what's being said. So you might get some of the subtleties in the turning away or the tipping the head back and that kind of thing, but actually that might just be postural or positional, sorry, rather than them refusing. And it's just those little bits that make for a successful mealtime. It's really, obviously, really incredibly important to ensure that they've got access to their communication method. It isn't always appropriate for them to have access to high-tech eye gaze right in front of their face, but even if they've got another method, which is quite often we will advocate for lower or lighter tech AAC to support those meal times. And obviously it's really, really important to ensure that your communication is really, really consistent and kind of reflects the calm and taking your time kind of attitude that's needed during mealtime. The other thing that we talk about is that chatting versus non-chatting. So sometimes it's really, really important that you are not asking lots and lots of questions during a mealtime, because if they start trying to answer, if they are verbal, they start trying to answer, you're going to open their airway, and that then increases the risk. But equally, sometimes I will ask for chatting and that question asking during meal times for some of my clients, because they might self-feed, but their pacing is really, really fast and dangerously fast. So that natural chatting is a way of kind of slowing down the pace that they're eating. And again, that should be written and quite explicitly within the mealtime care plan. It's obviously a really nice opportunity as well to express hunger or thirst, and obviously to listen to their food and drink preferences. Another really important one is obviously the environmental factors. When you are in a school hall or a community space, I'm sure you've all experienced that kind of noise, that chatter, everyone chatting or really, really distracting, which can obviously lead to an increase in muscle tone and spasticity for some of our clients, and may also be distressing for some of them. It's really, really important that while we don't take away that social opportunity, that we also make it safe and comfortable for that client as well. So quite often, or sometimes, if the noise is too much or too distracting, we may well suggest something like a lunchtime club. So they have their peers for that social interaction, but it's in a separate space. They might have, it might just be them and maybe 2 or 3 of their peers. So just to ensure that it's really, really safe. Obviously, if we can promote them staying within their peer group and stuff, obviously we would. Visual distraction can be really, really tricky for some of our clients. So as well as other people, artwork and stuff in school halls can be really, really distracting and overstimulating, which can again make those meal times unsafe. You might see difficulties in pacing, either too quick or too slow. If they see their friends leaving to go out to play, you might see that a really, really hurried kind of finishing of the meal. Time is obviously a massive one as well. In schools, meal times can often be hurried and time limited. Quite often I will advocate for my clients to come out of their lesson just before lunchtime, 5 minutes early, just to make sure they can all get set up and get started. And that time limitation is quite often not sufficient for an individual who requires mealtime support. Eating and drinking obviously has to be safe, but should be enjoyable as well. And it can't be both of those things if it's rushed. Sensory inputs are obviously massive, which is why we work so with. I was saying when I was talking about the oral prep stage, involves all of those senses to make it nice and safe. So that saliva generation happens because you have smelt and seen that food that's coming towards you. So we need to consider those sensory variables when assessing an individual. it's so important to think about how food is presented. So often I've gone into day centres or schools where for ease it's kind of all been blended together, which I understand as a time limiting factor, but it does then mean that the individual gets presented with this, excuse me, brown or grey sludge that is not appealing at all. So I would always advocate for the elements of a meal to be blended or made to the appropriate consistency separately, so they can see, they can choose different tastes as they want them. They might just want just carrot, not carrot and peas and mash and everything else. There we go. Yeah, so obviously we identify that hyper or hyposensitivity and watch for those indicators of over or under stimulation, which can either lead to that sensory overload or that inability to engage with your mealtime. Is that okay, Kerry? Have I done everything on that page? Yeah. Excellent, and thank you.
You have. There you go.
Okay, so other factors to consider. There's obviously tons, and I've only written a few on here. But that oral hygiene and that identification of dental pain can be a real element of our dysphagia assessment. Poor oral hygiene can lead to the development of plaque, which then develops into gum disease and dental decay, which can cause a lot of pain. Bacteria in the saliva can make aspiration a lot more risky. So it's really, really important that we consider things like using a high fluoride toothpaste, using potentially low foaming or a different flavour of toothpaste, and specialist toothbrushes as well. So I'll quite often recommend things like that within my assessment. It's really, really important to think holistically rather than just at the mealtime that's happening. Obviously, visual or hearing impairment can have a huge impact on the way that the individual might enjoy a mealtime. And has a real impact on that anticipation, which obviously happens at that oral prep stage. So that that development of that saliva to manage the bolus effectively is kind of missing there if they are blind, and they might miss out on some of the communication elements if they are deaf. So it's really, really important that information and the mealtime is presented to them in a way that they can access. Behaviour as communication is obviously a massive one for us, and the cognitive impacts that behaviours and the individual can then lead to. So you might have fatigue, so it's really important to consider the possibility of size and frequency of meals, and then also you might have forgetting to swallow. So you might want to reduce the distractors, add in some verbal prompts. You might want to think of bolus modification or adding in some fizzy alerting kind of drinks. So you might think about changing the temperature of something to particularly cold, or the taste of particularly sour, to alert them and prompt that swallow. There's also things like ethical considerations. So we always think about the 4 factors: beneficence, so doing something in someone's best interests; non-maleficence, so doing something to always avoid deliberate harm; respecting their wishes; and then the equitable distribution of resources. You also have cultural, religious, and socio-economic factors to consider, and that can be things like cutlery, grazing versus meal times, who would be able to support with feeding, the potential of limited cooking facilities or difficulties in how to prepare food. They're all things that we think about and consider when we're thinking about putting together our mealtime care plans. And obviously there's therapeutic intervention there. Some NHS speech therapists don't necessarily have the funding or the capacity to be able to deliver some therapeutic intervention, but there is some things that can be done. If you think about talk tools or things like IQ Oro or use of the BioZoom, there's some things that can be done to potentially develop some skills there. that's also worth considering. Next, please, Kerry. Thank you. So, as I said at the very beginning, that collaborative working is absolutely vital. Although when you have somebody who's displaying those signs of dysphagia, you would refer to a speech and language therapist, we certainly can't do our job without all of these other people involved as well. So a physiotherapist would look at positioning, seating, motor coordination, and also other things like respiratory system management and chest health. For an occupational therapist, they'd be looking at the positioning and equipment, any sensory requirements, and also facilitating that independence, as well as the impact of cognitive, perceptual, or behavioural impairments on a mealtime. And then you've got us. Obviously, speech and language therapists will look at the safety of eating and drinking, considering that holistic picture, like I said, potential equipment that might make things a little bit easier, saliva control, communication, and that staff training element as well. A doctor, you might have an ENT or a gastroenterologist involved, as well as them considering medication and saliva control for saliva control or reflux. A dietitian would provide advice on nutritional requirements, weight management, and then enteral or parenteral feeding. Psychologists might support with positive behavioural support during a mealtime, plus all the others. So we've got parents, school staff, health visitors, dentists, nurse, pharmacists, lots and lots of people can be involved in making a successful and enjoyable mealtime. Those pharmacists might well be involved in considering alternative administration for some medications, and also the potential impact of medication on dysphagia. So when to contact us. Basically, I guess the bottom line is if you have any worries or concerns at all, we're always more than happy to chat through things, even if it's not necessarily quite appropriate for us. We're more than happy to put your mind at ease. And I'm sure that would be the same for any speech therapist. But if you see that increased coughing during or just after eating or drinking, choking incidents requiring physical intervention or first aid, repeated chest infections, and those aren't just the cyclical kind of winter chest infections that a few of my clients are susceptible to. That's repeated chest infections throughout the year. Increased refusal of food or drink, becoming gurgly or breathless when you eat and drink, that eye watering that I mentioned, mottled or flushed skin during or just after food and drink, and that significant increase in burping or sneezing during meal times, which is your autonomic response. So, to summarise, dysphagia is a medical term for difficulty managing food and or fluid. It's obviously a really, really complex process that happens super quickly and can leave lots of potential for difficulty. It's really, really important to consider positioning, communication, and the environment to ensure a successful mealtime. But consistency is key. So when that mealtime plan is in place, that should be really, really prescriptive and have an awful lot of information in there. It's really, really important that it's followed by everyone across environments. And like I said, if you've got any concerns at all regarding an individual's eating or drinking, please always contact a speech and language therapist for advice or assessment.
So thank you so much, Laura, for that amazing presentation. It was really, really informative and enjoyable. Thank you so much. So we're going to go now to the discussion. So I'm going to have a look at the questions. My apologies, I did bring them up on the screen at one point before I realised that everyone could see it in the middle of my screen. So I do apologise. So the first question, Laura, is what sort of red flags would you be thinking with the recurrent burping at meal times that you've mentioned?
So sometimes if you get really quick or repeated burping, that can often be to do with something called being aerophagic, which is quite often what you see when somebody is bringing the spoon to their mouth and breathing in all at the same time. So they're taking in an awful lot of air at the same time as their food. And what that opens up the potential for is your windpipe opening because you're breathing in that air, but also your stomach being full of air, which is where the burping comes from. So it's just another element that we look out for.
Thanks, Laura. Jenny has actually gone on here and said that her son sometimes does this, and they've been told that it's the aerophagia too. But she said that this is a really useful and informative session. And she's going to be referring the care agency to the video as an essential training resource and using it for PA training for young adults. So that's really nice to know. Well done, Laura.
Fab. I hope it'll be useful.
Well, it's certainly been useful to me, Laura, but I think it's been very useful to everyone. So Chrisanna then says, would you always recommend that even with a low risk that schools should have a swallow plan in place for individual pupils?
I would say if there was any risk there at all, it would be definitely a good idea to minimise that risk. So yeah, for sure, I would absolutely recommend that.
Thanks, Laura. Who said this? Jenny has said, with the blending all the food together, that's a really good point, and the best way to do it, and it's what they prefer. Like you say, her son always has his preference, but if he's in a hurry, he'll choose to eat them together for ease. So yeah,
absolutely, which is what I do too. If you're in a hurry, you're more than happy to eat things all at once. But if you're really taking your time over an amazing Sunday roast, you're probably not going to want it all mashed together in kind of into one. And it, like I said before, it really helps develop that that preference.
Oh, we've lost Laura again for a minute. Well, hold on a moment and just see if she pops back again. She might just have frozen. Let's see what this extra message. While we wait for Laura to come back, Jenny, no, you're not saying too much at all. It's lovely to hear your point of view.
Is there any more questions you want me to help with, Kerry?
Yeah, please. Yeah, Jenny's just said here that water, mayonnaise, gravy and milk. She her son loves pizza and he has it minced and moist, blended with enough hot water to make it pizza porridge.
I love the sound of pizza porridge. Might need to use pizza porridge.
Sounds nice. It's a nice name too.
It is a nice name.
I think that's actually it for the questions. Unless anybody else has got any more questions at all. Oh, Laura's back as well, but she's just on mute. Don't worry, Laura, we're just going through and there's no more questions, but if anybody has any more questions that, I'm back. If anybody has any more questions afterwards, then please do feel free to email us, email AT Therapy, and we will be able to answer those questions. Laura, we've just gone through to the end. Jenny was just saying that her son has pizza porridge.
Amazing.
And she's given us lots of useful information, but there's no more questions. So I was just saying that if anyone has any, they can email AT Therapy, info@AT Therapy, but also that this is going to be on our YouTube channel. There is just a comment here from Amanda to say thanks so much, Laura and AT Therapy, great training. And Sally says thank you, that's been so informative. Someone else says thank you. We'll just move on to the next page while we do that. Okay, so resources on the AT Therapy YouTube channel. There are lots of different training videos. This will be there, so we can have another watch with Laura. And there are lots of different really useful videos, some ones like this length, but also some shorter ones. go on to any of our AT Therapy social media accounts for freebies and strategies and just general updates. We've got lots on Instagram, actually. We've got some there, and then we've got some extras. So we've got at AT Therapy Limited, there's AT Therapy Ellie, AT Therapy Lois, I've got one, AT Therapy Kerry. And then, of course, we have our AT Therapy Facebook account and Twitter. So just Google us on all those searches. Keep up to date with what we're doing. We do quickly, before we do this, we've actually got a poll. And I wondered if I could get you all just to quickly fill in the poll, please. I'm just going to share it now. Oh, it's not letting me. Chris, I don't know if it will let you.
It's already been done, Kerry. Thank you.
Oh, sorry. Thank you. Just a couple more thank yous on there. And then, so the next upcoming events, we've got some Makaton training level 1 on the 23rd of March. That's at our offices in Oldham. So you can come and see where we are. And it's delivered by Sally Theaton, one of our AT therapy experts. And that will be a lovely fun day. And then in April, the lovely Nikki Jones, who is one of our clinical managers and highly specialist speech and language therapists, is doing a day's course on Play Included, which will be fantastic. So go on to Eventbrite to book on. And then let me just move that, and then we can see our next lunchtime webinar is on Thursday, the 24th of March, 12 to 1 o'clock. Get yourselves booked on. It's going to be Ellie Pettigrew, who's one of our speech and language therapists, specialist speech and language therapists, and she's talking about how to be a supportive communication partner for early communicators. So again, go onto Eventbrite, look on our social media pages and book on. So thank you very much. And we hope to see you again soon. Please do get in contact if there's any questions. Thank you, Laura, for a super session.